So I'm going to talk about the genomic assays and its role in deciding the adjuvant treatment for breast cancer. Trust me that I won't bore you with all the massive clinical data from the various clinical trials. Just to highlight a few points and some of the recent updates on the clinical trials. So how do we assess the risk of breast cancer patients? So basically, we rely on the clinical pathological criteria, including the tumor size, the lymph node status, the age, the tumor grade, and also, of course, the markers like ER, PR, and HER2. And all this information can be integrated and using the computer-based model like the Adjuvant Online. But nowadays, we have all those genetic tests, particularly the tests on the groups of genes, so-called genomic tests. So this might be helpful in deciding the best treatment for the patients, particularly whether these patients needs to have a chemotherapy or not. So there are different options for adjuvant systemic treatments for patients, including chemotherapy, endocrine therapy, which includes the selective estrogen receptor modulators. The most commonly used is tamoxifen, and the aromatase inhibitors and anti-HER2 treatments. So I'll focus on the adjuvant treatment for early stage breast cancer. So there appears to be some insufficiency in the clinical pathological parameters in assessing the response in this particular group of patients, namely those who are HR hormone receptor positive and HER2 negative breast cancer patients. For example, those larger, with the tumor size larger than 0.5 centimeter and low lymph node involvement. So, of course, for this group of patients, you usually give endocrine therapy as adjuvant, but whether the role of chemotherapy is a little bit controversial. So another group would be those hormone receptor positive and HER2 negative breast cancer patients who had 1 to 3 lymph nodes positive. So again, in this group, the role of chemotherapy is not that certain. So based on the NSABP B14 trials, the chance of relapse in patients with ER positive and lymph node negative was at 10 years is about 15%. But if these patients are given chemotherapy, the risk of recurrence will be reduced to about 11%. So it appears that there's small benefit from chemotherapy in about 4% of patients. But however, one should note that most of patients will not benefit from chemotherapy. That is, the 85% of patients actually can do well even without chemotherapy. So the task would be to identify patients who will benefit from chemotherapy either with or without toxicity, and to identify those group of patients who won't benefit from chemotherapy. And of course, most patients, if they receive chemotherapy, will have toxicity. So there are a number of genomic assays available in the market, and the most commonly used one would be Oncotype DX, which has the most abundant clinical trial support, and it is based on 21 genes, and the other, of course, have some clinical data yet, but they don't have much data to support their predictive of the benefit of chemotherapy. So let's describe a little bit about the Oncotype DX genomic assay. So the current indications for the Oncotype DX assay would be mainly for those with stage 1 or stage 2 disease with ER negative patients. So it is a test with 16 cancer-related genes, with assay of 16 cancer-related genes and 5 reference genes as listed on this slide. And from this assay, they had a score which is based on a certain formula. And for those who had a recurrence score less than 18, these patients will be classified low risk and would not benefit from chemotherapy. And of course, the high risk, the intermediate risk group, and the high risk group. So the Oncotype DX is the only trial with is only test with clinical trial supports that these can be predictive of chemotherapy benefits. So just some updates on the TAILOR-X trial, which actually is an outcome study, prospective trial in patients with HER2 positive, hormone receptor positive, HER2 negative, and lymph node negative disease, and tumor size of either 1.5 to 5 centimeter in the greatest dimension, or smaller tumor, but with intermediate or high tumor grade. So altogether, there are over 10,000 patients, and the recurrence score of 0 to 10 was about 16%, and these patients had endocrine adjuvant therapy with endocrine treatment alone without chemotherapy, and the 5-year invasive disease-free survival was 93.8%, and distant relapse-free survival was 99%, and relapse-free survival 98.7%, and the overall survival 98% as well. So the results can be, the clinical outcomes cannot be better, and therefore from these excellent results that it is difficult to believe adding chemotherapy will benefit this group of patients. So these are the survival curves. So you see that very excellent. So this just an example show that this young lady with 1.5 centimeter tumor and invasive ductal carcinoma and ER/PR positive and HER2 negative grade 2, and this group of this patient had Oncotype DX test done, and the score was 4, and therefore this patient is probably have over 98% surviving and 5 years, and therefore this patient probably will not benefit from chemotherapy. So another test, the MammoPrint test, and they had this MIND-AD clinical trial result published just last year, and in this study they had 6,700 patients with early breast cancer, HER2 positive, and HER2 negative, and hormone receptor positive, T1 to T3 operable. Initially, all were lymph node negative, but later they have revised the protocol and to include lymph node those with 1 to 2 lymph nodes since 2009, and they use both clinical pathological factors according to the Adjuvant Online, along with the 70 gene signature, the MammoPrint test, to stratify them into 4 groups, and therefore they have those the clinical pathological risk assessment is concordant with the genomic test, so the treatment will be according to the established protocol. But for those who there's a discordant results between the 2 assessments, then this patient will be randomized. So this is how they randomize the patients. So basically, those the 2 groups in the middle will be either those who have a high risk genomic assay or and low clinical risk, and therefore this patient will randomize to either adding chemo or not. So that applies to those with no genomic risk and high clinical risk. So if we look at the results, So basically, their primary endpoint would be to look at just one cohort of the patients. That is the patients who had high clinical risk but low genomic risk, and those patients did not have chemotherapy. That is this particular group of patients. So they set points that if that the 5 years metastatic-free survival of this group of patients is more than 92%, then they said that this study is a positive result in that this mammoprint test can be helpful in really identify a group of patients with very good prognosis. So chemotherapy is probably not necessary. But if you look very closely and comparing those patients who had chemotherapy on without, you see that in all the subsets of patients, there actually are small difference in the survival rate of 1 to 2%, whether they had a low clinical risk, high genomic risk, or a high clinical risk and no genomic risk. But we still have to wait, and this comparison between the randomized groups were regarded as the secondary outcomes. So we don't have that any significant difference between these groups being reported. So that's all the updates I want to share with you. So thank you very much for your attention.